Welcome to PopHealth Week, streaming live on Healthcare Now Radio. I'm Greg Masters, co-founder and executive producer. Joining me in the virtual studio is partner and co-founder Fred Goldstein, lead host and president at Accountable Health, LLC. PopHealth Week is your destination for unfiltered conversations with the visionaries driving population health forward. Whether you're a payer, provider, patient vendor, or policymaker, this is your go-to hub for fresh strategies and insights into population health best practices. Want to stay connected? Visit popupstudio.productions or message me on Twitter via @GregMastersMPH, and that's Greg with 2 G's. And do follow the show at PopHealth Week. To reach Fred direct, visit www.accountablehealthllc.com. With no further delay, Fred, who's in the seat today?
Thanks so much, Greg. On this episode of PopHealth Week, my guests are Dr. David Nash, the founding Dean Emeritus at the Jefferson College of Population Health, and Dr. Doug Romer, the Chief Medical Officer of MedsEngine. We'll be discussing MedsEngine and their IT system for physicians and clinicians that integrates real-time, evidence-based insights to streamline care, achieve nation-leading control rates, enhance medication adherence, and reduce healthcare costs. And David and Doug, welcome to PopHealth Week.
Great to be here.
Great to be here. Thank you.
Yeah, it's fantastic, David, to get you back on. Obviously, you've been on quite a few times. We really appreciate your insights. But when we start, let's turn it over to you, Doug. Give us a little sense of the problem we're going to talk about today and where it's at.
Well, the problem really is the control of multiple chronic diseases. They just are not being controlled. And as a result, what do we have? A lot more heart attacks, a lot more strokes, kidney failure. I could keep on going on. And the bottom line, as a family physician, there's a lot of suffering and death, and it's something we shouldn't have to look at so frequently.
So let's dive in a little deeper. Let's talk about hypertension in particular. Why don't you begin with that?
Well, interesting. Blood pressure is the number one killer in the world. It has been an issue for almost 3 decades. It was interesting back in 2020. Jerome Adams, our Surgeon General, came out and had a call to action because we then dropped to 43% blood pressure control rate, which means 57% of the U.S. has uncontrolled high blood pressure. It's just a pitiful number for this particular country. You fast forward, and I noticed in the Washington Post, Tom Frieden comes out and says, hey, this is the number one killer in the world, and we need a breakthrough experience. And part of what I'm trying to do is get that breakthrough experience. I think we're putting a dent into it.
So when you think about that, what's causing that to happen?
Well, I think there's a lot of socioeconomic things that have been going on, a lot of social determinants of health that we've been having going on in the country for a long period of time, from our eating habits to salt to alcohol to exercise to access to care, even if the care is not going to be the greatest. So you have a lot of those things happening. And the biggest thing is once you get it diagnosed, it's just not being treated very successfully. So no matter what the cause is, once you get there, we're not getting it under control. And that's really what my focus has been for a long period of time, is to get this under control.
Well, I'll jump in here, Fred, and thanks again for the invitation. I'm like the bad penny that keeps showing up on Pop Health Week, and I'm so appreciative of the opportunity. And certainly, Dr. Doug Romer is right, but let's go to 50,000 feet. And the real issue at the top of the forest is the healthcare system is not designed to improve health. And our listeners know that, but I think that my job here is to get us back to the big picture, which is no kidding that we can't control hypertension. No big surprise. And sure, of course, the social determinants, the moral determinants, as Don Berwick likes to call them, a society with the challenges that we have and poverty, crime, lack of education, gun violence, all the rest. However, the core problem is we have a market-based healthcare system that cannot possibly deliver the improvements in population health. Everything else is important, but a sideshow to the core problem. So, no surprise to me, every system is perfectly designed to achieve exactly the results it gets. We've known that. Thank you, Paul Plesic, for 40 years. But the real issue is a market based system cannot deliver improvements in health.
So we have these guidelines, we have these approaches, we have these treatments that apparently work. Where's the breakdown?
Well, I'll start and then Doug can give you the solution. The breakdown is something that, Doug and I and you have been working on really for 3 decades. And I can explain it in 3 words. Unexplained clinical variation, which is a fancy way of saying I went to the University of Rochester Medical School, so I know how to treat high blood pressure. Whether you know how to do it or not is not of my concern. And what I learned 40 years ago is exactly what I'm going to do, back in the office. And off we go. So the number one core issue is the marketplace. The number two issue is unexplained clinical variation, which basically says, hey, this is how I was taught to do it. This is how I'm going to do it. And that leaves us with about a 50% probability of getting it right. Now, graft on top of that, all the new science that we've learned, which I'm too old to remember anyway, all the new approaches, all the new guidelines, and confusion in the marketplace about which guideline from which major subspecialty organization. So it's absolutely no surprise to me, given this overlay, that people get it right, get the right treatment, probably less than half the time.
Yeah, I would comment, David. It's interesting with the guidelines that we had. They're excellent. They're detailed, but hypertension alone is 214 pages. How
Right,
the heck am I, as a primary care physician, going to know all those particular details? When
right.
we were breaking this down, we also found out there's 37 different things that I need to know about and then go find in the EHR and then run it back through those guidelines to come up with a recommendation. And the neat part is I completely agree with the we have to have a uniform process, and that was one of our goals. Uniform process, take out the variability, so you no longer have good doc, bad doc, well trained, untrained. My
Right.
APP knows more or less. We got to be doing it the same way. And as I've said when I spoke occasionally, this is why airplanes hardly ever crash, but our patients often do,
That's
and
exactly right.
it happens way too often.
So, talk a bit about MedsEngine and what you've designed or built to start and solve that problem.
Well, there's a couple of our goals. Obviously, number one is how do we follow the guidelines and use all those particular variabilities? We're doing it for 4 different chronic diseases. So, with the 4 diseases we're using, we're up to like 850 pages of guidelines. How do I do that in a primary care office, which literally has a very, very limited amount of time? They're on a hamster wheel day in and day out. How do I find all those variables and how do I get them through the guidelines? So that's going to be the tough part. And how do I do it in a uniform way so we get rid of that particular piece? The next problem I got to use is it's got to be very user friendly. I've got to be able to get through here efficiently. And then at some point in time, all those things need to be personalized to the patient. They need to understand this is me, this is my problem, this is the severity of my problem. And part of what we end up doing is to try to give them a picture of their disease, that severity. And by the way, this is the guideline recommended recommendation, and let them explain this is for them. And my only job now is to explain those particular guidelines. So that's the problem that we were trying to solve and solution. And then the mechanism is kind of the fun part of how we end up doing that.
And you mentioned the 4 diseases. What are those?
Hypertension is number one, type 2 diabetes, cholesterol, and then heart failure with reduced ejection fraction.
So you touched on the fact that obviously there's this click issue that doctors face today. It takes all these clicks to get through a system and put the information in or get the information out. You talked about aggregating these data sets. So can you talk about how the system works and takes those 800 plus pages of guidelines to create an output useful for the physician?
Yeah, so the important thing is I need everyone to visualize if they're sitting with their physician in an office. Invariably, there's an EHR. Hopefully, you're both looking at it at the exact same time. And if you have one of those four chronic diseases or all of them, we literally place a small button within the EHR. And once you push the MedsEngine button, all that's saying is we're going to work on this. But in the push of that button, and I can't, it happens faster than I can say it. Literally, there's a message that goes up to the MedsEngine cloud. It comes back. It's looking for 160 variables because that's what I need to potentially treat all four chronic diseases. It then grabs those variables or the EHR gives them. It goes back up into the cloud. It goes through those 845 pages of guidelines and then comes back to the EHR. And that happens in about 3 seconds. So now my job when we were doing this was the interface. So now it was how do I get a picture that a patient can resonate to and go, oh my gosh, yeah, that's really me. That's really my data. And we use red, yellow, and green. Most people know that red's probably not a good thing. Yellow's a little better, and green's great. So they get the idea we need to get you to green. And then what happens at that point in time is now we simply drop down. We talk about the severity of the illness, why there's a problem, explain that. And then we go to, hey, this is what the guidelines are recommending. And there's little notes there for the doctors to emphasize if it's particular to them. What the patients see is number one, I really understand my problem. And actually, for hypertension, their response to me was, Dr. Romer, I can finally see my blood pressure. It was no longer that silent top number, bottom number, magic number that we give people. They could see it. And then all I had to do is explain why this medication is best for the cause of your blood pressure. And then we go from there. That was very important because interestingly, when patients would come back, their blood pressure is normal. I would just, going to refill the bloods, talk to them, ask them, do what I got to do. And they would say, hey, can you do that test again? Because I want to make sure those red bars are gone. They wanted it to be green. And you know what? If it increases compliance, it's huge. And the other part is if I get the guideline recommended drug, but the patient doesn't take it, it's not going to help anyway. So as a result of that, this becomes also something that markedly increases patient satisfaction and compliance. So that's how we're getting some of the blood pressure control rates that we're getting.
Why, I think it's fantastic, one, because typically you see these systems and it's not for the patient to be sitting there and take a look at it, but it feeds back the information to the physician. But as you point out, that's only part of the problem, only part of the solution, because at the end of the day, the patient has to be comfortable with what's recommended and obviously comfortable to then go on and take and adhere to those medications. So it's fascinating that you actually considered that in the output for for this program.
Well, initially, the easiest way to do this was black and white and gray. And I kinda said, "Hold on, can we" I asked the IT guy, I'm just a doc. I said, "Can you guys make this into colors?" They said, "Well, sure." Didn't know to ask for that. And actually, each one of these modules has that red, yellow, green, and patients do not like their numbers or anything to be in red. Go ahead, David.
Well, I was going to say Doug could get into a little bit more of the science behind MedsEngine, which is pretty impressive. What I was going to suggest, Fred, as most clinicians know, especially over the last really 10 to 15 years, we've had American College of Cardiology, American Heart, and others fighting over, what's the right blood pressure target. So that's vexing to most clinicians. That's one challenge. Second challenge is the number of new drugs and our deeper understanding of what exactly is the etiology of hypertension. Third challenge, of course, is the health equity issue since people of color suffer disproportionately, so their access to care is lower. I mean, everything is stacked against this super common treatable challenge. And that's why, again, we're at such a low level of efficacy and effectiveness in treating it. So along comes a new technology, then we're into a new discussion of the adoption curve of new technology, right? So how does that work? Well, younger doctors who dabble, they'll be the early adopters, and the vast majority in the middle will wait to see what happens. And we know that this could be a 10 to 15-year time frame from when we get new technology to its appropriate wider adoption and distribution. So it's remarkable to me that this super common problem has so many issues stacked against it, which sort of makes sense as to why we get it right about half the time. So I'll yield the floor back to Doug because the science behind MedsEngine is sort of so elegant in its simplicity, and it's easy for folks to get their head around. So maybe, Doug, you could give us like a high level 2 minutes on what exactly, what are some of the factors that MedsEngine looks at, and how does it deliver the answer?
Just tuning in? You're listening to PopHealth Week on Healthcare Now Radio with host Fred Goldstein, president of Accountable Health LLC. Stay tuned for the rest of the story.
Yeah, so one of the things, we started doing this back in 2005. If you go back, the U.S. blood pressure control rates then were around 28%. This is back when physicians didn't even measure themselves, but I kind of said, if we're going to do Lean Six Sigma, we're going to start doing quality theory, we have to measure. So we got them to allow us to measure. And we were so much better than the national average. We were at 40%. So only 60% of our patients were not at goal. With that, we're following the guidelines the best we can. We began to look for different technologies, and we actually found that there's a group at a Mayo Clinic that was using something called impedance cardiography, developed in 1946, has been going along. We looked at it and said, you know what, the definition of insanity is doing the same thing, so we decided to do something different. So now we use what I call it, I tell patients, I'm going to do a blood pressure ECG or a blood pressure ICG. And they look at this and what's that? I said, there's going to be a lead on your wrist. There's going to be a lead on your ankle. It's going to take literally 1 minute. We're going to do 3 20-second tests and average it. Interestingly, the data is very, very solid. I now know exactly what the cause of their high blood pressure is. And that's the data. We have 23,000 ICGs that literally say 47% of our patients have tight blood vessels. There's a current assumption that everyone has tight blood vessels. We found out that about 27%, literally, they don't have any tightness of the blood vessels. But right now, we're going to give them a 1 drug, 2 drug, 3 drug, 4 drugs that dilate these blood vessels, and it's going to try and fix a problem that doesn't exist. There's also a class that has a little bit of both. So once I know that, we've got existing drug classes to control this when I know the problem. And when we present it to the patients and the physicians, myself, we see those red bars, and that's when we personally select those medications to go after those red bars. This has been very successful in resistant hypertension. It's been out there for a long period of time. What we ended up doing was one of the few primary care groups that began to take this on. And then another quick story that goes back to what you mentioned about early adopters, late adopters. Our group's been at 92% blood pressure control rates for 10 consecutive years. We go to another group, and these guys were really high performers. They were sitting in the mid 70s, probably 74, 75%. And we introduced the technology, the software, and we had guys who jumped right in. So what they ended up with was about an 85% blood pressure control rate, not in the 90s. Why? Because some of the guys says, not me, I know everything, I'm doing it my way. This is the way I was taught in med school 30 years ago, and they did the same old. They stayed around 75%. Those who said, hey, we're going to bring in new technology, new thought process, they're at 95, 96, 97% blood pressure control rates. Average them out, what do you get? 85%. So it really backs up what you just said there completely with the data from a second group. And we haven't, there's different data that simply says the more you follow the process, which is exactly what you need to do while airplanes fly, the better results you're going to get. So that's what we end up doing. That's some of our additional data that we use to get these blood pressures controlled.
So, Fred, what an elegant explanation that Doug has offered. I'll translate it into the language of improvement, right? So, what MedsEngine has been able to do is take a time tested technology, right? Post World War II, basic, easy to do. Even I could manage it when I saw patients. And then the key here is closing the feedback loop to the doctors, right? So showing them instantly almost a pathway that makes sense visually, intellectually, but critically important, closing that feedback loop to both the doctor and the patient with an effective and efficient therapy. Without that closure of the feedback loop to give them the reassurance that if I am going to take the leap to change behavior, it better make a difference to my patients. Legitimately and understandably, that's a typical doctor pushback, right? Why should I change? I'm doing a good job. Well, when we confront you with the data that says you're a poor performer, and I offer you a solution instead of just castigating you. This is the beauty of this technology and the application via today, the electronic medical record, right? So it's elegant. It closes the feedback loop. It's based on solid decades of good science. It's reassuring to patients. I mean, it's really quite remarkable that it's not in wider distribution. And that's because of the cultural barriers.
Absolutely. And we've got just a really short period of time right here. Perhaps we could just quickly touch on the access program and how this could possibly work in that for those that choose to take that route.
Sure. So go ahead, Doug. You go first, and I'll give my view.
I was just going to say I like the two endpoints in access because there's two things they want. They want a blood pressure, systolic blood pressure drop of 15 millimeters of mercury. Well, that's pretty simple for us because we averaged 22 millimeters of mercury a drop, and the group that's 85% was at 18 millimeters. So that's a no-brainer. We can get there in no time flat. You can debate the 140 over 90 versus 130 over 80. They set it for, hey, at least a systolic less than 130. With our data that we're getting ready to publish, over 14,000 patients, we went back and said, well, hold on, our goal was 140 over 90, but what if it would have been 130 over 80? They want half of the patients less than 130. Well, with a goal of 140, we have 45% of those patients were already less than 130. So basically, not trying to get to 130, we almost hit the goal that they want to begin with. So this will be very, very simple for us to do. Anyone who wants to be in access or wants to get those numbers quickly, I think we can really help them. And most importantly, they'll get paid, but they will not have to see the sequelae of their patients with a stroke and the inability to talk, walk, etc.
Great observation, Doug. Uh, Fred, to me, access is another shot in the dark by CMMI to change how we treat chronic illness. Who would not support an improvement in how we treat chronic illness in America? So, I salute the idea, but the amount of money set aside to do this, and lots of smarter people than me have looked at access, and it's very interesting. I mean, it's really about changing the care model more than it is actually changing the prescriptions and which drug for high blood pressure. It's all about changing the model, which is why it's going to be an uphill battle and why you're going to roll that big rock up another hill. It'll be almost impossible at the level of money that they're offering on an annual basis. And without getting too much into the weeds, my understanding is there's a 50% holdback until you can achieve what they call the OAP, right? The
Yep.
outcome aligned payment. Well, what the heck is an OAP and what are the measures that they're going to use?
Yeah.
And how can you hold individual doctors responsible for the OAP when we know it's a systems impact and a system effect? So it's back to what I said. It's all about changing the care model. It's like a forced function to change the care model. I get it. We got to change the care model, but I'm not going to do it for $400 a year. It's just not going to happen. And good luck. I salute the idea. I think it's going to be an uphill struggle, like many other CMMI efforts. Great conceptually and operationally, very little historical positive impact.
Absolutely. Well, that's going to have to be the end. I really appreciate both of you coming on, an incredible discussion. At one point, we probably need to get into access and talk about that in more detail. But thank you, Doug and David.
Thanks again.
Thank you, Fred. Appreciate it.
If you'd like more information about MedsEngine and their product, you can go to medsengine.com. That's medsengine.com. Thanks for joining us. And back to you, Greg.
And that's a wrap for today, folks. A big thank you to our global audience for tuning in. If Pop Health Week resonates with you, show us some love. Give us a thumbs up on your favorite podcast platform. Share it with your network and do subscribe so you never miss a future episode. Remember, we're live on Healthcare Now Radio every weekday at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. That's 2:30 a.m., 10:30 a.m., and 6:30 p.m. Pacific. On behalf of Fred Goldstein, myself, and the crew at Healthcare Now Radio, stay safe, stay tuned, and we'll catch you next time.